Hello, I'm Bobby Jean Schweitzer, and I'm going to present on endocrine and metabolic systems, number 4. The lecture modules for this session includes pituitary disorders and adrenal disorders. Let's start with pituitary disorders. And a question. A 54-year-old patient being evaluated for a kidney transplant has a cushingoid appearance. She is found to have an elevated adrenocorticotropin hormone, or ACTH, level. Which organ should be further evaluated in this patient? A, the adrenal glands, B, the posterior pituitary gland, C, the anterior pituitary gland, or D, the hypothalamus. And the answer is C, the anterior pituitary gland. Answer C is correct because ACTH is produced by the anterior pituitary. Answer A is incorrect because the adrenals produce cortisol and mineralocorticoids. Answer B is incorrect because it is not the posterior pituitary but the anterior pituitary that produces ACTH. And answer C is incorrect because the hypothalamus releases cortisol-releasing hormone. Answer C is incorrect because the hypothalamus releases cortisol-releasing factor, or CRF, which then stimulates the anterior pituitary to release ACTH. So I'll show you this picture which demonstrates this quite nicely. So as you can see, the hypothalamus causes release of cortisol-releasing factor, which stimulates the anterior pituitary. Then the anterior pituitary releases adrenocorticotropin hormone, which then stimulates the adrenal glands to produce cortisol. Cortisol drives metabolic effects, and then there's a negative feedback loop from the adrenals back to the hypothalamus, from the adrenals back to the anterior pituitary. This is another demonstration of the hypothalamic pituitary axis that I showed you previously, but I want to concentrate on the fact that cortisol and the feedback loop suppresses both the anterior pituitary and the hypothalamus in a negative manner. Stress causes release of CRF, or corticotropin releasing factor, by the hypothalamus. And there's the positive metabolic effects of cortisol then mitigate this stress response back to the pituitary and the hypothalamus. So pituitary function, is important to realize that the anterior and posterior pituitary release different hormones. The anterior pituitary release prolactin, growth hormone, luteinizing hormone, follicle-stimulating hormone, thyroid-stimulating hormone, and adrenocorticotropin hormone. Good way to sort of remember it is all the ones that have the hormone in their name are released by the anterior pituitary, and then there's also prolactin, where the posterior pituitary only releases 2 hormones, vasopressin and oxytocin. And a good way to remember these are they're the only ones with vasoactive properties. So the ones with vasoactive properties are released by the posterior pituitary. The vast majority are released by the anterior pituitary. We're going to talk a little bit about hypopituitarism, or decreased activity. The etiology is most commonly related to tumors, postpartum hemorrhagic shock, radiation therapy, and surgeries. Symptoms of hypopituitarism are variable, but include hypothyroidism, adrenal insufficiency, impotence, amenorrhea, and infertility. A treatment is hormone replacement, or replacing whatever hormones are deficit or in low quantities. So one of the more common disorders related to pituitary disease is acromegaly. This is actually related to an excess of growth hormone. Growth hormone is produced by the anterior pituitary. The sequelae of this is skeletal and connective and soft tissue hypertrophy. There's hypertension and hyperglycemia typically present. Patients can have cardiomyopathies and even heart failure. They typically have an enlarged tongue, an epiglottis, and thickened vocal cords, which all make airway management more challenging. It's not unusual to have recurrent laryngeal nerve paralysis and hoarseness, or airway obstruction, or changes in voice. And there may be peripheral nerve entrapment. In fact, these patients often present with symptoms compatible with ulnar nerve dysfunction or carpal tunnel syndrome. The anesthesia considerations are associated primarily with difficulty in airway management, and both mask ventilation as well as endotracheal intubation can be difficult. One should consider an awake intubation and using a smaller than average tube. Let's talk a bit about adrenal disorders and start with a question. Which of the following patients is most likely to have adrenal insufficiency? A, an 18-year-old with inflammatory bowel disease who takes 20 milligrams of prednisone daily for the last year. B, a 74-year-old with a spinal fusion that received a recent lumbar steroid injection. C, a 65-year-old with COPD on ipratropium inhalers. D, a 55-year-old scheduled for colonoscopy under monitored anesthesia care who has rheumatoid arthritis and takes 5 milligrams of prednisone daily. And the answer is A, the 18-year-old with inflammatory bowel disease who takes 20 milligrams of prednisone daily for the past year. Answer A is correct because 20 milligrams of prednisone is enough to suppress the adrenal function. Answer B is incorrect because a single epidural steroid dose is typically not sufficient to suppress the adrenals. Answer C is incorrect because inhaled steroids typically are not sufficient enough to suppress the adrenals. And answer D is incorrect because anything less than 7.5 milligrams of prednisone daily is typically not enough to suppress adrenal function either. So the adrenals produce various hormones. One of the most important is glucocorticoids or cortisol. Glucocorticoids are produced by the adrenal glands and have metabolic effects, driving gluconeogenesis or the production of glucose. Cortisol causes protein wasting, causes free water loss. Glucocorticoids have a direct effect on the cardiovascular system to maintain blood pressure and vascular tone. Large doses will bind to the mineralocorticoid receptors. Elevated levels typically suppress in a feedback loop ACTH from the pituitary, and they suppress cortisol releasing factor from the hypothalamus. Mineralocorticoids are also produced by the adrenals. Aldosterone is the most common mineralocorticoid. It is not under control of the pituitary or the hypothalamus. It is regulated instead by the renin-angiotensin system. Aldosterone is released in the setting of hypotension and dehydration. It causes reabsorption of sodium and water to try to maintain volume balance, and it causes excretion of potassium and acid. Steroid doses greater than 7.5 milligrams per day, as mentioned in the discussion of the question, for greater than 3 weeks, may suppress the adrenals for up to 1 year. Not absolutely always, but may. There typically is not any suppression of adrenals if one is on 5 milligrams or less of prednisone daily. Adrenal insufficiency has etiologies that are related to the adrenal glands themselves, and this is termed primary adrenal insufficiency. The most common causes are autoimmune, hemorrhage, infarction, or infections such as HIV or tuberculosis. A secondary adrenal insufficiency is secondary to conditions outside of the adrenal glands that then affect the adrenal glands. And the most common cause is exogenous steroids, or patients who take typically prednisone or steroids to treat medical conditions. But also pituitary or hypothalamic dysfunction will cause secondary adrenal insufficiency. So what are the symptoms of adrenal insufficiency? Typically the patient complains of weakness, fatigue, anorexia or a loss of appetite, nausea and vomiting, flank pain, abdominal pain, They may have fever, altered mental status, even dementia, delirium, or coma. They may be dehydrated. They typically have orthostatic hypotension and hypovolemia, which can lead to hypovolemic shock. Laboratory findings include a low sodium or hyponatremia, an elevated potassium or hyperkalemia, hypoglycemia or low glucose levels. Primary adrenal insufficiency is associated with a low plasma cortisol, and the patient will have no response to an ACTH stimulation test because the adrenals aren't working properly. A CT scan may show adrenal gland hemorrhage. So the treatment is supportive care, hydration, volume resuscitation, electrolyte repletion, glucose replacement, intensive care monitoring, and replacement with glucocorticoids. Initially, hydrocortisone in 100 to 200 milligram IV boluses are effective. One should continue hydrocortisone in doses of approximately 50 milligrams every 4 to 6 hours. Once the acute illness subsides, the patient can be transitioned over to oral prednisone. Mineral corticoids should be given if there's a primary adrenal crisis. Remember, only primary adrenal diseases may result in mineral corticoid deficiency. Any secondary ones will not, since mineralocorticoids are not under the control of the hypothalamus or the pituitary. Fludrocortisone in doses of 50 to 200 micrograms orally can be given if the hydrocortisone dose is less than 100 milligrams per day. High-dose hydrocortisone will also have mineralocorticoid activity, and so fludrocortisone is not necessary if high-dose hydrocortisone is being given. Steroid replacement is always important in the perioperative period. In the past, it was advocated that we use stress dose steroids, and typically those were 100 milligrams of hydrocortisone, which is generally way too much for most patients undergoing most surgical procedures. So it's generally recommended now that one limits the amount of steroids that are given because excess steroids can be associated with adverse effects. So for minor procedures, it's recommended that the usual daily dose of prednisone be given to the patient. So typically just telling the patient to take their usual dose before arrival to the hospital is sufficient. One may consider giving 25 milligrams of hydrocortisone or its equivalent, either in addition or in place of the patient who doesn't take their oral prednisone. If the patient's having major surgery or there's a significant stress response to the illness or the surgery, then it's recommended that higher levels of hydrocortisone be administered, typically 50 to 75 milligrams of hydrocortisone IV preoperatively, and then for up to every 8 hours for up to 3 days postoperatively should be sufficient. Once the patient is out of this acute phase, it can be tapered to their basal dose, and the patient can be converted from hydrocortisone back to oral prednisone. If the patient has sepsis, which is often associated with a relative adrenal insufficiency, then hydrocortisone in dosages of 200 to 300 milligrams per day in divided doses are typically given until vasopressors are weaned off, and then the patient is tapered over a 3 to 5 day period. So what is Cushing syndrome? Well, this is the opposite of hypoadrenalism. This is the excess, this is from excess steroid. So the most common symptom is hyperglycemia, though only about 20% of patients will have overt diabetes mellitus. There's impaired calcium absorption and bone formation, so the patients have osteopenia and osteoporosis. The patients can have anxiety, irritability, psychosis, depression. They often have these skinny extremities, but truncal obesity. They frequently have hypertension, fluid retention, edema, even heart failure. They will have a hypokalemic alkalosis. These patients are immunosuppressed from the excess steroids and have an increased susceptibility to infections. The etiology is most commonly secondary, and this is due to an anterior pituitary microadenoma driving the adrenal glands and causing bilateral adrenal hyperplasia. Ectopic ACTH release or released from sources outside of the pituitary, from the related to small lung cell cancer or non-endocrine kidney or pancreatic tumors, can cause Cushing syndrome. Primary adrenal adenomas or hyperplasia cause Cushing's. Usually these are unilateral. About 50% of them are malignant. And the most common cause of Cushing syndrome is the exogenous administration of glucocorticoids to treat a variety of underlying or coexisting diseases. The diagnosis is usually with a dexamethasone suppression test. Dexamethasone should suppress further release of cortisol, or measuring urinary 24-hour free cortisol levels. One can also measure ACTH levels. In the presence of Cushing's or excess cortisol, the ACTH should be suppressed. If it's not, that's an indication that it's a pituitary tumor releasing ACTH. A CT of the abdomen may show bilateral adrenal hyperplasia or adrenal tumors, and a pituitary MRI is indicated to evaluate the pituitary gland. Preoperative preparation includes treating the underlying or associated hypertension, treating the associated hyperglycemia, normalizing fluid status. Generally, this is diuresing patients, correcting electrolytes. One can consider spironolactone, which is an aldosterone antagonist. There should be careful attention to positioning patients and moving them, as these patients are osteopenic and are prone to fractures. One should monitor for ECG changes, anticipate labile blood pressures. These patients typically have increased sensitivity to non-depolarizing neuromuscular blocking agents, and one should monitor and correct intraoperative hyperglycemia and electrolyte abnormalities. Let's talk about primary hyperaldosteronism. Usually the clinical picture of that is that of diastolic hypertension, hypokalemia or low potassium levels, a metabolic alkalosis, skeletal muscle weakness, but usually these patients do not have edema. And that is a big contrast between this and or Cushing syndrome. The laboratory diagnosis is an aldosterone-renin ratio is the best screening test. Measuring plasma renin levels help distinguish between primary from secondary hyperaldosteronism, and a CT scan to evaluate the adrenals to rule out masses. Treatment consists of the administration of spironolactone, as I mentioned, is an aldosterone antagonist, sodium restriction, and potassium replacement. Surgery is indicated if the tumor is greater than 4 centimeters or there's suspicious features of cancer, or for refractory hypertension that is not responsive to medical therapy. Thank you very much for your time.